just kept trying. We kept giving her loads of oxycodone, couldn't get her better. She had bad osteoarthritis in her knee. So I said, I'm going to improvise here. I'm going to put a lidocaine patch on her knee. And I did that, and then she could walk after that. She could walk around, and I said, I'm going to be academic, do an experiment. And I took it off again, and she couldn't walk after that. And she also felt much better with the reduction in oxycodone. So we just sent her home with this lidocaine patch on her knee, hoping that we wouldn't have to keep her in hospital another 4 weeks. So in some patients, you do have to go beyond the evidence and just try something out. You know, if you know what you're doing and it's safe, it's not too expensive, it's a reasonable solution. And I don't know, do you have Nefopam? It's an old drug which is creeping back into use in the Royal Infirmary, unfortunately, but it's very anticholinergic, a dangerous drug for old people. These drugs, codeine, dihydrocodeine, which effectively turn into morphine through metabolism, we're forced to use them in patients who are going home because you can't give people low-dose oxycodone easily when they go home. So cocodamol 8/500. If somebody needs extra analgesia is safer than a non-steroidal, and there are actually very few alternatives to that. So I have to say, as long as you warn people about constipation and look for side effects, it may be the only solution for, hopefully not for long-term use. So I just want to mention nutrition a bit. So thiamine deficiency is very common in hospital. Lots of studies back this up, and we haven't really strategically attacked this as a global medical community, thiamine deficiency. We talk about thiamine deficiency in alcoholic patients, which are very common in where we're from, and I don't know how commonly you see thiamine deficiency causing Wernicke's encephalopathy and brain damage, including Korsakov's, here in India, but it's kind of a common thing in Scotland, unfortunately, because of alcohol. But people are often in hospital for ages, 2 weeks, 3 weeks, and they're not eating properly and probably not getting enough thiamine, and they may be running out of thiamine. And I suspect that thiamine deficiency in hospital patients is a cause of brain damage, and it's one of the reasons why people do badly with delirium, because they don't eat and drink properly for weeks. Sometimes we might be giving them a bit of nutrition here and there, but they're not getting thiamine, which runs out pretty quickly. So I quite often give Pabrinex, that's the brand of intravenous thiamine that we have, in patients who are very thin, who look malnourished anyway, and then they've been in hospital for a while and you're thinking, I'm not going to risk thiamine deficiency, I'm going to fix that. And basically paying attention to nutrition is really important. Now, what about managing the agitated patient? There are two basic strands to this. Non-pharmacological and pharmacological. Looking for the acute cause is an obvious thing to do. Repeated orientation. So that keeping somebody unstressed, trying not to handle them. I think physical contact is usually perceived as assault. Patients don't like it. In terms of drugs, I prefer, for short-term use, haloperidol. I've had some success recently with low-dose risperidone over 2 or 3 days in making somebody feel better, controlling psychotic symptoms. But I generally only use drugs for violence or if there's intractable distress due to psychosis. That's usually, and again, I don't like lorazepam at all as a first-line drug because it makes delirium worse, but it can be used successfully as a second-line drug. What about treatment of delirium as opposed to managing agitation? Unfortunately, there's really nothing to say except that we don't have any treatments that make delirium better. We just have things that control agitation, psychosis, and benzodiazepines make it worse. That's all I have to say about that. Melatonin, some studies are coming out. Maybe that will come through. Just want to mention distress a little bit. This is David Aronovich, who's a well-known columnist in the UK who had bad ICU delirium, and he talked about it. And I think distress is something that we underrate and we don't look for. People usually don't admit to the psychosis that they have. You have to ask them actively. PTSD can follow delirium because people can remember it. So I think there is a role, if somebody's got distressing and untreatable psychosis, to use antipsychotics to treat that. I've mentioned persistent delirium. So in the studies that are available, about 20% of patients get delirium, still have it 3 to 6 months later. I just want to mention some new research that I was partly involved in. Daniel Davis is a PhD student in Cambridge. I'm co-supervising with Carol Brain, and he's exploited a data set from a study of 85 plus 80-year-olds, an excellent study in Finland, but he went back and looked at the data again and established for the first time the principle in people without baseline dementia, delirium has a massively increased risk of new dementia after this. Odds ratio of nearly 9. Worsening clinical dementia rating scale. And in the whole group, those with delirium this is over 10 years in a longitudinal study, delirium was associated with a worse MMSE and a more accelerated decline. And in dementia that's already established, we know from a study in Harvard that if you have delirium, the rate of decline on this memory scale is 50% faster in those patients between this point and this point. So, follow-up of delirium. We now know that delirium is a marker of current and future dementia. So we can either let these patients go, which is what happens now in most cases. We just let them go. We don't think about whether they've got dementia or whether they might get it. And risk of readmission is higher, family stress goes up. Or we can do this, which is good practice, to make a diagnosis through the usual methods. You can refer to specialists if you like, and we generally don't have specialists available to make this diagnosis ourselves, but we can start the screening process at least. And then, in appropriate people, try to get arranged follow-up. Because if you can get dementia early and start arranging care around that, including potentially with drugs, you reduce the risk of institutionalization and you reduce distress in that person. So it's a duty, really. And I just want to quickly mention prevention. It does work. There's substantial evidence which is amply documented in the 2010 UK NICE guidelines, but it's difficult to implement. These are the kinds of factors that you might want to consider: constipation, dehydration, and so on. This all takes time and effort. But just the evidence that we have is quite strong. This is probably the best study from 2001 in the Journal of the American Geriatric Society. And Ed Marcantonio basically gave these modules, and this is basically kind of geriatric medicine put into a systematic form, and tried to get the staff in these wards to implement these things with very good results in that patients had less delirium with this programmed approach to prevention and a reduced severity of delirium. I would say though that since that study came out and other studies, there's been a failure to implement prevention, and I think that's largely because it takes a lot of time and energy and effort. So I would say that instead of trying to do the whole caboodle of prevention, instead of doing that, use elements from now on, drug protocols that emphasize safe drugs, getting rid of constipation or preventing it if you can, and so on and so on. And these can be embedded.
Time is up, sir.
These can be embedded in routine care. So, last slide. I've emphasized that we have to use the right terminology, delirium. It's complex with multiple predisposing and precipitating factors. We need to treat causes as well as optimizing brain functioning. Prevention does work, especially if you choose the right drugs. And pay attention to the fact this patient in front of you may have dementia, which is one of the worst conditions there is. And doing a favour to that patient by highlighting the possibility of this and arranging adequate follow-up could dramatically change the quality of their life over the next few years. The leverage is very big. That's my contact address, and I just want to mention 2 websites: European Delirium Association. Our next meeting is in Belgium, and I recently set up this website that's got lots of free downloadable resources which may be of use. Thanks for your attention.
Thank you so much for the wonderful lecture on delirium. I think it is Lipowski who called it terra ignota.
Yeah, terra incognito.
What's the word?
Terra incognito.
Incognito.
Yeah.
That's right. And you've made it less that today, I must say. Thank you.
Any questions?
Thank you for the lucid lecture on delirium. I am Dr. Shamsher Dwivedi from Delhi.
one of the prominent features of any patient who has delirium is sympathetic overactivity. So in any effort to quantify delirium, and it has an implication particularly in patients who have cardiac ailments as a coexisting disorder. So in any effort to quantify delirium, I think sympathetic activity should also be factored in to signify the severity of delirium, maybe pulse rate or maybe some other features like perspiration. That is one suggestion. Please comment on that. And the second suggestion is that when we see patients, particularly elderly, who are staying at home and are alone, when we are treating them with features of delirium, we should always inquire about what is the how much is the daylight entering their rooms where they are staying, because that might have an implication for it might prolong delirium in such patients. So entry of daylight into the room or the environment where they are staying at home, I think that is important. And one of the common causes of delirium in an casualty, particularly in elderly, is urinary retention. So percussing the bladder should be an important part of any clinical evaluation for patients with delirium, particularly elderly.
Yes, thank you very much. Well, on the first note, I think some patients with delirium and delirium tremens, so due to alcohol withdrawal, particularly have sympathetic overactivity. And in fact, one study from Holland in ICU found that patients have an unexplained tachycardia a lot of the time in delirium, and we're not sure why that is, but some people say it's because we have delirium with the physiology as well. You know, we see delirium of the mind, but you know, the brain controls everything, so it may well be that the brain's governing role in physiology is also delirious, you know, so it doesn't know what to do, and you know, there might be, you know, too much sympathetic drive to the heart. So absolutely, I think that measuring physiological variables, it's an end organ, you know, disturbance which has whole body consequences, is very interesting research angle, but also something to think about in patients with delirium. As for daylight, certainly, I mean, people have talked about daylight therapy, and people are interested in melatonin. So this is all about optimizing brain care, isn't it? So it's about providing an environment that's stable, that's as physiological as possible, during the day, darkness at night, quiet at night. Trying to achieve that in hospital is very difficult sometimes, but if you can try and do as much as you can in quite a soft way to improve all those little factors, you may well end up with a very good outcome. And as for percussing the bladder and looking for retention, it's very common for that to be the cause of the agitation. And they may not even have delirium. They may just be so agitated, plus a bit of dementia with their urinary retention, that as soon as you fix it, they just go back to normal. I remember it happened to me recently. This man, you know, he was rolling around the bed and, you know, really struggling. And I said to the nurse, I examined him and I said, I think he's got urinary retention and he's very constipated. So we hit him with a double whammy of catheterization and phosphate enema. It was very satisfying. An hour later, the junior doctor saw it all happening. She said, he was sitting up and he said, I feel like a changed man.
Dr. Natarajan? I am Dr. Natarajan, neurologist. I would like to know your views on the relationship between sodium, delirium and dementia. The problem is we have different settings in relation to sodium, delirium and dementia. One, we have an acute hyponatremia, where there is an acute precipitous fall in sodium levels. Patients are treated, patients improve. They may not necessarily reach the normal levels of sodium levels, but still somewhere between 125 to 135. They improve clinically and stay as such. Another group are these patients who have not improved to the total levels and then come with recurrence of hyponatremia and delirium. There's a third setting wherein patients have hyponatremia, which is only a comorbid problem. They come with an infection which is probably the cause of the delirium. And incidentally, we find that the sodium levels are around 127, 128, which probably we feel do not contribute to the delirium itself. And there is another group who have a constant level going on, even when on follow-up, when we check their sodiums, they are in the suboptimal level. The question particularly which I wanted to know was, it's our experience, as you mentioned, 80% may recover, reversible as far as delirium is concerned, and in 20% it may be predisposition to a dementing illness, or maybe they might be harboring a dementing illness which has been unmasked by this delirium. So are these patients with low sodium levels, is it a biomarker to indicate that these are patients who probably have dementia or who are likely to develop dementia?
Dementia or delirium?
Dementia. They are already delirious.
Oh, you see, within the group with delirium. That's a very good question. I don't know the answer to that. But I do think that as we have an aging population who have lots of chronic comorbidities that are partly treatable, and sometimes you can't fix a hyponatremia, but if you can, then I think the principle of making everything as healthy and physiological as possible, could well be the case. And certainly there are people in whom you fix the hyponatremia who've been mislabeled as dementia, who get better, over time, or sometimes over months. But the exact question of whether hyponatremic delirious patients are more likely to have dementia in the future or have concurrent dementia that has never been diagnosed before, I don't know. But it's a very good question because it's such a major problem that we see in hospitals, isn't it? Something like 10 or 15% of people in hospital have hyponatremia. And if we found out that actually that was a particularly potent risk factor for poor outcome within delirium, then it would have very big therapeutic implications. So thanks for the research idea.
I'm Dr. Kushal Jain. I'm consultant psychiatrist from Delhi.
I can't hear you.
I'm Dr. Kushal Jain. I'm consultant psychiatrist from Delhi.
Right.
Yeah. One of the common thing that we do a lot of licensing work with hospitals where we are called for evaluation and management of delirium, which is of course the outcome of the medical conditions. But one thing that strikes me very often is that in the elderly patients, there is a long-term low-dose benzodiazepine dependence. That's a benzodiazepine dependence of low dose. They got prescribed like 0.25 or 0.5 alprazolam for sleep for a GP, then they keep using it for years together.
Yeah.
And then suddenly they develop some cardiac condition or any other problem and they land up in ICU. And then on second, third day, because they discontinue the alprazolam, they land up in delirious state. And then all the medical parameters are normal, and except that there is not sleeping and he's getting agitated. Traditionally we should not use benzodiazepine for management of delirium, but my experience, limited experience, is usually when you reintroduce that same dose or by a bit of half of that dose of benzodiazepine, they recover faster. What do you think?
Yeah, I think that benzodiazepine withdrawal, as I hope was on briefly on one of the slides, benzodiazepine withdrawal is a very important cause of delirium, and it's often missed. And for example, patients who can't eat and drink, they often, because for example after stroke, they fail a swallowing assessment, and it's not common practice to start giving parenteral or rectal benzodiazepines in these patients, but I've quite often diagnosed delirium due to benzodiazepine withdrawal in these kinds of patients. So absolutely, people who've had it for ages, I never change. I don't even reduce the dose. I just keep it the same while they're in hospital, unless they're very sleepy. And I advocate that over the next several months, when they get out of hospital, if they survive, that the dose is reduced. But another very interesting thing about benzodiazepines is that quite a lot of studies show that if you give benzodiazepines to somebody, you reduce their MMSE chronically. So it's a cause of dementia, or a dementia-like state, where you impair somebody in a very serious way that can knock them into the level where they need institutional care. So they're awfully dangerous drugs precisely because they're so seductive.
Thank you for a nice lecture. The Glasgow Coma Scale, how reliable is it for a person who is A, delirious, B, aphasic?
B what, sorry?
Aphasic.
Well, it's a crude scale with respect to delirium in the sense that it picks up disorientation and drowsiness. But I would say that any acute change in the GCS is strongly indicative, of pathology. As for aphasia, it doesn't work. The verbal scale, you immediately lose a point because you can't answer the orientation questions, and even worse, you may not even be able to follow commands. So a kind of robotic approach to the GCS, which sometimes you see is not the right thing to do. Same applies to other cognitive tests.
So, sir, the best verbal response cannot be tested in a person who is aphasic. That point would go away.
Yeah.
Okay.
Thank you.
Thank you. Thank you.
I'm Dr. Sunil from Kochi. I'm a geriatrician. It was a very good talk. I have only one clarification. The single question that you spoke about, who do you address it to? To the relative?
Who the authors
or
are.
to the nurse in the hospital?
The squid. Sands and Ryan, Palliative Care 2010, I think, is the reference for that.
Yeah. Who do you address that question to when you ask?
Oh, the informant. The informant.
Who's the informant?
The informant is usually a relative, and in that study it was a relative.
It was a relative.
But I think that doesn't apply in hospitals that much, because about 50% of delirium is incident delirium.
Correct.
So if you know the patient, the nurses are actually the best guide. So I think that's one of the flaws with the squid, is that it didn't specify the informant, and I think we need the 4AT. I'm not saying it essentially incorporates the squid in the 4th A, which is acute onset, yes or no. But we use a variety of sources.
But what do you do in a hospital setting where the nurses are changed? They have the shifts, and different nurses are looking at the same patient. So sometimes it might not be.
What I would suggest is the Delirium Observation Screening Scale, which was developed in the Netherlands. It's a nursing scale. It's implemented, would you believe, in 50% of Dutch hospitals now, because the government in Holland started to get worried about under-detection of delirium, and they now inspect Dutch hospitals and financially penalise them if they don't detect enough delirium. And so the Delirium Observation Screening Scale, which came from 2001, I think, great scale. It's filled in. It takes about 2 minutes. The nurses fill in at the end of the shift, and it's anchored in a fairly objective way, we've attempted to use it in a trial in my ward, and it worked quite well, but it's a long process to get people into the mindset. But that is a very good scale, and it's well worth considering looking up.
Thank you.
When we were training several years ago, complex visual hallucinations were thought to be delirium, especially alcohol withdrawal delirium.
Yeah.
So pink elephants and little men marching down the windowsill and so on and so forth. But then, of course, in the last few years, say a decade, we know that older people with Lewy body dementia or multi-infarct dementia or a number of other conditions can have complex visual hallucinations.
Yeah.
So the significance of complex visual hallucinations in delirium is one question as a diagnostic indicator. The other question is, can you think about both exogenous and endogenous causes for delirium? And I'm asking this in terms of the environment. Many of our hospitals are closed environments with artificial lighting. And you have a person who's completely unfamiliar and who has severe sensory deprivation very often in one modality or the other. How much do those things contribute to the delirium? Has that been studied?
Okay, well, in terms of complex visual hallucinations, that is a real diagnostic problem. And I have very often seen patients who don't have inattention, which is the core diagnostic feature of delirium, but who describe very elaborate complex visual hallucinations. And they don't fit that into anything, do they? They don't even have dementia. They've just got something wrong with their brain that generates this. And I generally pass that over to a psychiatrist. I give up. And I say, I don't know what the diagnosis is here, and I just pass it over. But I try and do as good a cognitive assessment as I can, try and get a history of onset. But quite often, patients have had them for months. And it's actually an incidental finding. And they might have had a delirium, but I've been referred patients with query delirium, and I've congratulated the referring doctor for having used the word delirium. But it's turned out that the patient's lucid, gives this account, and it's some other problem which I then pass over. As for the environment, I think it differs from patient to patient, but certainly hospitals are very bleak places. And I'll tell you one quick story. I had a patient who had vascular dementia, been in my ward for 10 weeks, which is a very long time. Usually our length of stay is less than 10 days. But his memory wasn't that bad, actually. But finally he was going to a nursing home, and it was justified in his case. And we had this big campaign a while ago to have signs to tell people where the toilets were, and so on and so on. But the room is still very grey and bleak. So he said, yeah. I said, you would be happy to move in. You have all your own stuff, your own photos. And he said, yeah, it'll be better than this room. The only picture I've got is that. And he pointed to the sign on the toilet door. So he was living for 10 weeks. He was living in this cell, effectively, in this grey cell, which did have had a window. So I actually think that the patient. I haven't talked about this today, but the patient experience and psychosocial stress is really important in delirium because people are terrified, perplexed. They don't know what the hell is going on, and being kind to people, smiling at them, telling them what's going on repeatedly. Bringing relatives in the morning instead of waiting to visiting hours, photographs of family, laminated sheets telling them that this is where you are, this is what's happening, you are safe, you don't need to worry. Because any of us have been trapped in an airport, when we don't know if our flight's been cancelled or lost a wallet or something. It's a terrifying experience, and we're, cognitively able, we can work out what's happening. These patients have worse experiences of that lasting for weeks. I think it's very important, and the nice thing about it is a lot of it's fixable. So I definitely believe that making hospitals nicer places in how we conduct ourselves, eye contact, smiling, orientation, as well as how we decorate rooms, how we control light and dark, how we keep the hospitals quiet at night, all of these things are really important, actually.
I have a question, I have a question, if not then a suggestion. Does your website also talk about the things which need to be done definitely in the first 8 hours or 24 hours, that sort of investigations? Because often what happens is we ask the junior persons to actually investigate the people with delirium. And one of the very, very important things which they think is very important is what you said, either an MRI or a CT scan, rather than a thorough physical examination and see that there is no. So is there any scale which says these are the things which need to be done in the first 24 hours or the 8 hours, and then you can do it, some of the things can wait longer? Or is there something like that?
Well, it's a very timely question because we recently had our quarterly meeting of the Scottish Delirium Association, where we were trying to develop a Scottish pathway for delirium, and that was a big part of the conversation, was how we should guide junior staff to not do too many CT scans, because CT scans, they're quite useful things, but in the acute delirium they very often yield nothing, and there's also an opportunity cost. It takes the attention of the doctor away from the patient. They're wheeled through a hospital, they sit in a trolley. I think that makes the delirium worse sometimes, so you have to target CT appropriately. So the pathway that we will be putting up, hopefully within a few weeks, on the Scottish Delirium Association website will have that. There's already a pathway there from Fife which covers many of these issues, and it's public domain. We put it on this website, the Scottish Delirium Association, not the European Delirium Association, purely just so people can use it if they want, and also correct it and improve it. But there will be a universal Scottish one agreed by this group on the website in a couple of months, I hope.
The last question.
So, okay. Thank you for the excellent lecture, sir. Please. Thank you. I have two questions actually. In your investigations for delirium, you have how many patients do you have no cause found actually?
Say that again, sorry?
How many patients do you have who have no cause identified? What do you do about them?
About what I do about them?
Yeah.
We'll answer that now?
Yeah. The second question is, why delirium is considered a risk factor for dementia? Or is there any pathophysiology for it?
Okay. So, in terms of delirium where there's no obvious cause, and that's quite common in medicine of the elderly practice, because we often get the hard cases, that have been in general wards for a long time and we can't fix them. And some of these patients we never succeed, we never get them better, and they emerge into a kind of dementia-like state. But those are the types of patients that I would look for the rarer causes. So I start with a very detailed examination, physical examination, looking for things like sacral pressure sores that might be tiny and it might be missed. Even if you're looking for sacral edema, unless you completely strip a patient and look every square inch, you might miss a joint inflammation or some sort of cause. So that's the first step. It's limb ischemia, grumbling cholecystitis maybe, or some sort of condition that's been missed. So it's a thorough physical evaluation, look at all investigations. So it just requires attention to detail. If that all fails, then third line investigations include doing autoantibodies, or antibodies for pulmonary-spastic encephalitis, and I've picked up a couple of those that presented with delirium. And strokes in strategic locations, I think, is another way. As for dementia resulting from delirium, it's a very interesting question. Patients with delirium don't eat very much. They're often dehydrated. They're very stressed. They lose lots of muscle mass because they lie in bed a lot of the time. I think that there's a big physiological insult associated with delirium, and because the brain uses 20% of the body's energy and relies very much on a good blood pressure, I think there's simple things like that the brain is getting damaged in acute hospitals in a big way. I think it's very, very important that we take good physiological care of people with delirium and we feed them properly, because 2 or 3 weeks can go by where their blood pressure's been 104, where they're not eating or drinking, where all sorts of things are happening, which we know from animal studies you don't need to drop the blood pressure in an old rat for very long before it loses lots of neurons. So until we do proper imaging studies and proper outcome studies, we've actually got a paper just coming out which found that in patients with delirium after hip fracture they had a higher S100B level in the cerebrospinal fluid, which is a traditional marker of brain damage. So that's one of the first pieces of hard evidence that people with delirium have brain damage. So taking great care of these patients in a very detailed way is, I think, our best guess at the moment.
Thank you very much, Professor McLeod, for your wonderful and descriptive presentation.
Thank you.
Thank you very much. And we are adjourning for 1 minute.
Take your seat, sir.
Okay.
Yeah, yes. Thank you very much, sir. Professor. We request the chairpersons. May I request the chairpersons, Dr. Subbalakshmi and Dr. Ramanujam, to honor Professor with the certificate. Thank you, sir. May I request Dr. E.S. Krishnamurthy to honor the chairpersons with the certificate, please. We now adjourn for lunch. I request Dr. Sai Lakshmi to take charge of the walking poster session. I request the presenters of the poster to finish their lunch quickly and be near their posters so that it will be easier for the judges to judge the posters. And we request all the delegates to view the posters and have a nice time. We adjourn for lunch now.
We are starting the post-lunch session with post-lunch session. May we request Dr. George Thomas, Saint Isabel Hospital, Chennai, and Dr. Abhishek Srivastava, Kokila Ben Dhirubhai Ambani Hospital and Medical Research Institute, Mumbai, to chair the session on the topic The Falling Elder by Dr. John Davison, RCP, Edinburgh, UK.
Good afternoon, everybody. Welcome to the post-lunch session. We'll discuss about very important thing which we all see in our day-to-day practice. That is falls. All of our elderly, our grandparents had a fall. We have fall in our family. Why is that important? Because 40% of elderly, more than 65 years of age, had a fall, and 1/3 of them have hip fracture, which has a lot of morbidity and mortality per se. So in this session, we'll have two talks. One on falls, how to assess and prevent them, and second, how we can prevent the impact of the fall by treating osteoporosis in a more efficient way.
Thank you. It's my great pleasure to introduce to you the first speaker, Dr. John Davison. He's a consultant physician and geriatrician from Newcastle upon Tyne Hospitals, NHS Trust, Royal Victoria Infirmary and Freeman Hospital. You will notice that both of us chairpersons belong to the orthopedic specialty, and both the speakers are general physicians, which actually reflects on the fact that orthogeriatric co-care, as it is now called, is a team job. And orthopedic surgeons, rehabilitation doctors, physicians, neurologists all have to work together in order to achieve good result in these patients. When I was a young student, elderly people in India were rare. And now it has become very, very common to have people living, and that is a great, great achievement for Indian independence. That at the time in 1947, life expectancy in India was 39 years, and today it is 67. A huge jump in one generation. So Dr. John Davison is the Assistant Director of Medical Education, Newcastle upon Tyne Hospitals, NHS Trust, and Northern Deanery. He has many publications to his credit, and he has developed the first specialist falls and syncope service for Western Sydney. He was awarded a PhD from the University of Newcastle upon Tyne. He's a principal consultant for the falls and syncope service. I wish we had one in India. At the Royal Victoria Infirmary, the largest unit of its type in Europe. And therefore, I think he's particularly well qualified to give us an insight into this difficult problem. Thank you, Dr. John.
Thank you. I feel quite privileged in many respects. I feel privileged to have been invited to come along here today. I'm privileged to have done my training in geriatric medicine in Newcastle upon Tyne, and Newcastle has a very strong history of understanding and recognising that the needs of older people are different from those who had previously been seen by specialists. And I think it's rather serendipitous that the invitation of my first trip to India should come to somewhere like Chennai, which itself is pioneering in geriatric medicine within the country of India. So I think a combination of those circumstances maybe has some fate to it. I thought I would quickly just give you an outline of where we're going today. So, a brief overview of the epidemiology of falls, a reflection on some of the work that has been done in falls epidemiology in India, and comparing that with the epidemiology that's international in terms of UK, Australia, and the US, which have been the predominant research publishers in this field. A little bit about the evidence base and about effective falls interventions, and I think if we reflect back to Professor Maxwell's talk this morning on evidence base is something that we struggle with in elderly care and geriatric medicine. And that's often because those people who are included in studies are not necessarily representative of the people that we see. So I think whenever I use the word evidence-based, I think it should be applied with a degree of common sense, something which I think as geriatricians usually feel we are rightly proud of holding, sometimes over and above our specialist colleagues. And also a recognition of complexity, which makes scientific understanding of the conditions we look at more difficult. So I'm moving on from there to something a bit more practical and pragmatic, and having been given the post-lunchtime slot, I think we need to interrupt things about midway through my talk for those who are feeling like nodding off. and a few take-home messages at the end. So what is a fall? A fall isn't a diagnosis, so it defies a very strict and clear definition. Larry Rubenstein in UCLA looked at saying that it's an event that's resulting in a person inadvertently coming to rest on the ground or another lower level. So that accounts for those people who actually don't intentionally end up where they were, but don't necessarily end up on the floor. And he's also included the perhaps slightly controversial bit, with or without loss of consciousness or injury. Because the element of syncope, patients who end up on the ground who report having fallen, but who may have had a preceding syncopal event, is worth being aware of. Within Europe, the European Union funded a group of research collaborative projects, one of which was about trying to improve definitions. And the profane work, unfortunately, is no longer funded, but the website still gives some of the information that is present from those working groups. So I thought I'd start off with, again, epidemiology that originated initially within Europe and the States, but also then compare and contrast with the epidemiology that's originated from here. As we mentioned, about a third of patients over the age of 65 will fall in any given year, and that is probably an underestimate. And that's down to reporting issues, that's down to people who have sustained a fall who don't want to admit that to the medical profession for fear of the event becoming medicalized. The percentage increases with age, so 3/4 of people over 85 will fall. And again, depending on the environment, within Newcastle, 45% of our emergency department attendances are associated with a fall or the fall-related injury. And often it's the fall-related injury which gets treated, but the underlying fall and the precipitants for that fall get ignored. The numbers vary again in terms of those who end up within a secondary care facility, but if you've attended an emergency department, about a fifth of those people will end up in hospital. And our fracture rates in the UK are probably slightly lower, but again, is that because falls are being underreported and it's only those that make it to secondary care that present with the fractures? When looking to supplement my talk with illustrations, I typed in India traffic in Google. And you'd be pleased to hear that India traffic #1 hit is a motorcyclist in Chennai. And I put that there because falls are the second commonest injury behind those of RTA. And we can see some of the presenting features of those who are most likely to be involved in RTA are going to be on two-wheeled motorised vehicles. Those who sustain the most injuries are going to have more than one pillion passenger. And those who do sustain injury are less likely to be wearing helmets. So there's a public health message that comes out of that, which is obvious. But in fact, it's that underlying and indolent additional preventative component that we can do about the second most common injury, falls, that I think is the take-home bit from here. So extrinsic falls, so falls due to slippery surfaces, are reported in about half of those cases presenting to secondary and tertiary care. Yet that doesn't really look at the differences between those who are younger and those who are older. So when you look at research that has perhaps looked more focused in the elderly care age group, again, we've got half of people over the age of 60 reporting falling. And then when you look at things like total fall rates, and this is a study that came out from Bangalore, you're looking at estimated up and attached to the whole population, 160,000 fall-related deaths in India per year. You're looking at a mortality rate of 271 per 100,000 people in those over the age of 70, which is 18 times higher than in those under the age of 70. Fall and injury rates are more prevalent in women, and we recognise that about 2/3 of the presentations with falls do occur in women. Some of that reflects the demographics of women tend to be those who are going to reach that age in a higher proportion. So the research evidence in terms of epidemiology is out there. The numbers are huge, and I think as a consequence of the numbers being huge, there can be a bit of a nihilism about, well, it doesn't matter what we do, we're still going to see tens of thousands of people who fall over, so why bother doing anything? And what I'd hope to convince you about is that there are lots of risk factors which are amenable to change there. There are risk factors which we can regard as intrinsic, so those are things that are pertinent to the individual, and the commonest ones are looking at muscle strength, lower limb extremity strength, ankle dorsiflexion, quadriceps strength. Those issues with lower limb muscle weakness will combine with other cerebral causes to impact on gait and balance. Don't forget about vision. And it's not just purely visual acuity that we need to think about, it's things like contrast sensitivity, the ability to define an edge, a curb, where the surfaces are uneven. Proprioceptive problems, neurocardiovascular abnormalities, which can include the decline in your baroreflex function with age, so that changes in posture can lead to reduction, even if it's transient, in cerebral blood flow, and that too will impact on balance. If only transiently, it's enough to then lead to a fall. The extrinsic factors are often things we can do something about, although again there's a certain nihilism about modifying environmental factors. Addressing things within the home environment can certainly reduce risk of falls at home. Polypharmacy, again harking back to Simon's talk this morning, thinking more carefully about what it is we're giving, and in the context of falls, thinking about those risk drugs rather than just the number of drugs alone. So when the epidemiology was produced looking at falls, it was clear that an independent risk factor for falls was being on 4 or more medications. So that was work done by Mary Tinetti in the States in the 80s. 4 or more medications in the 80s was a less common occurrence than 4 or more medications now we're in 2012. So the advent of secondary prevention therapies in stroke disease, cardiovascular disease, the increased use of statins universally, we have to think, are these additional drugs numerically causing the problem, or do we actually need to be specific and pinpoint those drugs which put you at a higher risk of a future fall? The bar graph that I've presented there was work that I did looking at emergency department attendees who had recurrent falls. Almost universally, there is at least one problem with gait or balance in these individuals. Medication, as in multiple medications or the presence of a fall risk medication, was present in over 50%. And as you can see, other factors are also present and identifiable. And I think the key point there is that there was a median of 5 fall risk-related factors in each of these individuals. So again, it's part and parcel of geriatric medicine is, once you've found one thing, don't stop looking. Look for the second thing. Then once you've found the second thing, look for the third thing. And it's about continuing that process of not just taking for granted that you've found the answer first go. It's re-evaluating the patient and re-evaluating whether there's something else that you're missing. Again, listening to my predecessors, there was one of the phrases that Alistair used, which is one that echoes with me in my teaching, is attention to detail. And I think that's what makes a difference between an average physician and a good physician, is thinking about those particular factors and questioning everything rather than just taking things for granted. And the bottom component there, the synergism. So having one risk factor may make you slightly more susceptible, but once you've got 3 or 4 risk factors present, you've got an exponential rise in the risk of you actually succumbing to a fall event. Again, I said I was privileged to be here in Chennai, and this is work that came out from Professor Krishnaswamy at the government hospital here. And this looked at about the same time as I was conducting my study, and I think you'll see that there's a certain similarity between the bar graph here and the bar graph that I presented before in terms of the risk factors. So again, musculoskeletal risk factors, which are going to be contributory to gait and balance abnormalities, are the most commonly identified problems and have potential for improvement, if not a cure. You're certainly going to improve those parameters. And I understand there are a large number of physiotherapists in the audience today. Hands up who's a physio. Hands up higher who's a physio. Be proud of it. Because the physiotherapy component, and when we look at interventions, is crucial to making a change for these individuals. I was pleased to see that syncope, which was one of my specialist areas and one that delights me no end, appeared with 20% of these patients. So again, it's thinking laterally about why these individuals fall. Visual disturbance is a higher factor here than it has been identified in the European and US studies, but medication, again, 42% of the individuals had a fall risk medication identified, hypnotics and sedatives being amongst them. So thinking pragmatically and practically, I think that's why I'm not a professor. I think it's because I'm still very much feel in my heart that I'm the person who does the day job and I leave the intelligent people to do the other work and help guide me in what I'm going to do. Attention to detail again. Rather as with delirium, the history is crucial here. And it's about asking all of the questions and asking other people to verify those. So what were the circumstances? I say to my trainees, what I'd like you to do at the end of this consultation is come out on stage. Can you still hear me? I want you to be able to come out on stage in front of this audience of 300 people and say, this is how Mrs. Smith came to be on the ground. And be able to enact it for me, because you can't act out that fall if you haven't really got an idea where they were, what they were doing at the time, were they carrying shopping, were they looking to cross the road, was there a distraction, was somebody else talking to them, and all of those other issues. Oh good, you're going to let me be mobile. It upsets the camera when I do this. So again, I think it's very crucial that for you to be able to take a full history, you need to have that understanding of what were the circumstances. But not only do you need to know what the individual patient thought happened, you want to know who was with them, because what did they actually see? So the patient who presents to me who's got panda eyes because they've gone down like that hasn't just tripped. They may have done, but there's usually something else going on. The person who's got a Colles fracture, they may have tripped because they've had an opportunity to put their hands out to save themselves. So that are those worrying factors that make me think, is there something else going on here? Was there another contributor before the start of that full process? Ask about arthritis, ask about pain, ask about those restrictions in joint movement that you may have. Think about the gait and balance problems. Was there something predisposing this individual to falling? We've mentioned medication history. So medication, an absolutely crucial component there. And it's the detail that's important here. It's not just, are you on medication, are you on a lot, let's see the list. How many times have I said to somebody, okay, tell me what you're on, and they say, list about 6 different antihypertensives. And I'll say to them, and when was that one started? And they'll go, oh, that was about 3 weeks ago. And when did you first fall? Oh, about 2 weeks ago. And when did you fall again? Oh, about a week ago. And have you had any other symptoms? Oh yeah, I've been more dizzy. But unless you ask the question, you don't get that information. So the patient is telling us something there. Culprit medications have been a topic of great research, and I've put a few quotes down there which I've cleverly put in white so you won't be able to read them. But I'm thinking about, are there specific groups of medications that increase your odds ratio for falling? So things like antidepressants have an odds ratio overall in the meta-analyses of about 1.7, going down to things like diuretics, which in the large-scale studies only come out with an odds ratio falling of about 1.2 with fairly tight confidence intervals. And things that you might think would obviously increase your fall risk, like opiates, in meta-analysis don't come out as statistically significant. But if you choose the individual and you think about the individual to whom opiates may be related, that shouldn't stop you stopping the medication or considering it. And then, as well as those specifics about medications, as I said, think about these red flags. Think about asking the questions about symptoms induced with posture. Are they lightheaded? Are they dizzy? If somebody tells me they're dizzy, my heart no longer sinks, it used to. It now opens up a bank of different questions. What do you mean by dizziness? Can you say dizziness in a different word? Are you able to discern, is this a rotational component or is this a lightheadedness? I'm wary of treading on Nikki's toes because she's talking about this tomorrow, so I shall keep it limited. Are these patients unsteady on standing up, but are they unsteady for a long period of time after they've stood up, or is it just a transitory phase? So you're thinking about those with postural hypotension. As I mentioned before, think about the facial and head injuries, disproportionate injury to what should, to you or I, be a simple trip or stumble. And think very carefully about that fall with no apparent hazard. I've lost count. I had a patient the other week, and I was asking about his falls, and he told me that he fell on the way to the local shops, and he went back after his fall, in which he sustained a laceration above his eyebrow. He went back and he looked at the pavement, and the pavement was fine. It wasn't a usual Newcastle County Council pavement with stones up like this all over the place. It was smooth. But his natural assumption was, I've fallen, there must be a reason, there must be an explanation, I must have tripped. So again, question that if there isn't an apparent hazard. And we'll come back to loss of consciousness. So summarising that, these are the type of questions I think you should all be having in a fall history. Where was it? What were the precipitants? What's the medication? What do they mean by dizziness? I put family history on there. Why have I put family history on there when you're taking a fall history? Osteoporosis. Just because I'm a falls doctor doesn't mean I don't think about the consequences. And I think it's this integrated approach we need to consider, is that yes, a lot of these patients present with a fracture and the fracture gets treated and they go out the door and nobody thinks about the fall. But as a falls physician, we run the risk that we manage the fall and we don't think about the potential for fracture. So asking about family risk factors for hip fracture is also an important component of that history. So, examination. Where are I? I'm about 12 minutes in. In my job as Director of Medical Education, one of the things I have noticed that is about this time of day is usually the time that people start to nod off. So I'd like you all to stand up. Now I'd like you to all stand up. Simple, straightforward tests will give you an idea of your increased risk of falling. So, can you all now stand on one leg for me, please? And can you maintain it? Now all of those who are under 60 should be able to manage 20 seconds. Now close your eyes. How wobbly do you feel now? Like to swap to the other leg, because that's quite a good discriminator if you've got some asymmetry going on there. So in those, you can all sit down now. Thank you. But going back to the delirium issue, there are some simple, straightforward things you can do that are very easy. And one of those easy things to do is to do a one-leg stand. So the odds risk for falling in somebody who can't sustain 10 seconds of a one-leg stand is twice that of somebody who can in the older age group. And they incorporate that within scales such as the Tinetti performance-related mobility score. Is a one-leg stand is one of the multiple components of assessing gait and balance. But it's a very simple, straightforward screening thing to do. If your patient can't manage that, you've got a lot of information straight away. I'm so glad I've got two chairs here. We will utilise one chair for a timed up and go. So again, Mr. Chairman, if you'd like to, before, don't, on my command, if you'd like to stand up, walk to this point here, which is roughly 3 meters. Obviously, I would measure it accurately if I'd got my tape measure with me in the luggage. Stand, come to this point, turn around and go and sit down, and observe what happens. And have a seat. How quick was that? 5 to 6 seconds, yeah, pretty good. Anybody else, any of the physios like to comment on this technique? Timed up and go test. Did anyone notice our chair use his hands to help get himself up on his feet? Yes, he's a worry, isn't he? Right. But again, I say that to my juniors who have admitted somebody to acute ward who've come in with a fall, and I say to them, what was their tug like?
And I get these looks of, hang on, what are you asking me this for? I want to be a cardiologist.
But it gives you so much information for a very short period of time in terms of the examination. Yes, we want to go into the in-depth bits. You know, a role of the medic is to make sure that there's not an ejection systolic murmur, to make sure that you're not missing that aortic stenosis, to make sure that they are in sinus rhythm and they're not having long pauses as you examine them. Think neurologically, yes, we're looking for movement disorders. You're looking for those patients who've got Parkinson's disease, asymmetry, who've got neuropathies. There's all of this additional component. But rather, as with delirium, you can do some straightforward things, and if you're not getting your answers with the straightforward things, you just need to have in your brain those expanded questions, that list of extra things that comes out at that stage when you're perhaps struggling to find a straightforward answer. I think it's Menkel's law that says for every complex question, there is a simple and straightforward answer, which is wrong. And that's very much the case with falls. Falls isn't straightforward. It's worth thinking about the complexity issues. I've put